Next we have Dr. Chaithanya Warrior, who will be talking about diplopia causes due to orbit. Dr. Chaithanya is a consultant pediatric ophthalmologist at Chaithanya Hospital, Tiruvalla.
Good morning, one and all. Here I am going to deal with diplopia causes from orbit. Orbital causes of diplopia can be due to orbital wall involvement or orbital spaces and vascular and soft tissues in the orbit or ocular muscles. So it can be due to orbital trauma, orbital mass lesions or orbital inflammatory syndrome and thyroid eye disease. Basically, the mechanism behind this diplopia from orbit will be either mechanical or restrictive and paralytic. Restrictive causes will be from orbital fracture with muscle entrapment, thyroid eye disease, or scar tissue due to any cause relating to the orbit, or like the orbital inflammation and restrictions due to the orbital tumor involvement. Mechanical, orbital mass lesion can limit the movements. Paralytic causes due to non-isolated cranial nerve palsies leading on to the pathology at the cranial sinus and orbital fissure. So we need to evaluate the patient with a detailed history, clinical examination, imaging is a very must, and follow-up is the underlying key. So if a patient complains with sudden onset diplopia, we are suspecting causes from the orbit. And if it is sudden onset, we will suspect vascular or ischemic pathology. If there is a pain or discomfort, it will be mainly inflammatory related orbital microvascular ischemia. If there is no sudden onset, it's long duration, basically non-vascular. And pain and discomfort is not there, non-inflammatory orbital mass related, either restriction or mechanical. If the pain is there, definitely inflammatory causes from orbital myositis, Graves' disease or abscess or infiltration. So, if a patient with multiple cranial nerve involvement with diplopia and no neurological sign, the tug of war will be between inflammation or infection and mechanical orbitopathy at the posterior orbit or cavernous sinus. So we need to do definitely a contrast enhanced MRI of orbit with or without brain imaging. Coming to few scenarios, diplopia associated with other signs from the orbit like ophthalmoplegia, proptosis, chemosis, facial numbness, loss of corneal reflex and abnormal pupillary reflex. So definitely the diagnosis is a cavernous sinus syndrome. Need to rule out the causes. If the same case with cavernous sinus syndrome features along with vision changes, papilledema, definitely we need to look for causes from the orbital apex. If diplopia with infection, features of infection and ophthalmoplegia plus with fever and immunosuppression, we need to rule out the orbital cellulitis. If there is ophthalmoplegia with history of trauma and signs of trauma along with diplopia, we need to rule out orbital wall fracture or retrobulbar hematoma. Coming to clinical cases, 8-year-old girl came to the OPD with compliance of her diplopia. 1 month history of RTA was there. Her vision is 6/6 and she was evaluated elsewhere with CT brain and it was normal. See, on her photographs, she is orthophoric. Looking to her video, she is orthophoric for the cover and uncover test. On ocular movements evaluation, can see a very minimal limitation of elevation in the right eye. So I sent her for CT orbit. It revealed inferior orbital wall fracture with inferior rectus muscle entrapment. It's a white eye blowout fracture. Definitely the eye will be white, intact orbital rim in children with soft tissue herniation and vagal phenomena will be there. But for her, there was no vagal phenomenon. So in all cases of white eye blowout fracture should not be missed and CT scan orbit is a must. She underwent orbital floor repair and in this video can see her elevation is full and she was free of symptoms. Coming to the second case, a 6-year-old girl came to OPD with swelling and redness in the left eye with no pain. and diplopia was there while looking out and up. Uncorrected visual acuity was 6 by 6, and when I elevated lid, there was a reddish elevated mass in the supraorbital region, suspecting acute dacroadenitis. But for that, the child will be febrile or pain will be there. See, I am lifting both eye very easily. Child is cooperating. There was no pain. So I asked mother, again fever, trauma, joint pain, nothing was there. Again with the history, I got a positive relevant history. She completed the treatment for leukemia, probably ALL 2 years back. So definitely we need to rule out the metastasis, and it was a difficult situation for the mother to accept and refer to her treating oncologist. Case 3, a 10-year-old boy with pain and double vision while looking up for the 3 days. History of fever was there, vision 6-6. On examination, there was a supromedial elevated congested mass, turned out as myositis, treated with antibiotics and steroids, he resolved. Coming to the 4th case, a 65-year-old male with complaints of diplopia for last 2 years. Vision was 6 by 9, both eyes. On examination, there was ptosis in the left eye. Ocular movement evaluation revealed there is limitation of elevation in the left eye in all cases. And there is a reddish salmon pink mass in the upper orbit. It's a turn out as lymphoma. So always, if there is ptosis, please always lift the upper eyelid to see any underlying mass. A 33-year-old male complains of diplopia while looking to extreme right side. Best corrected visual acuity was 6 by 6. On gross photograph, there is a very abnormal palpebral fissure in the right eye. Ocular movements and cover test revealed it as orthophoric, and ocular movements were full. He had a very minimal diplopia towards the extreme right gaze. He was a dysthyroid case, and now he is euthyroid. And when the proptosis, everything resolved, the palpebral fissure asymmetry was there, and he underwent a cosmetic tarsography. Coming to this lady, she complains of diplopia while looking up. This photographs reveal the eye is out, eye is down. Here our ocular movement evaluation revealed the elevation is limited, and she is a case of dysthyroid, hypothyroid lady. It's because of the thyroid related issues, and she was referred again to endocrinologist, and when the thyroid status become stable, if again diplopia is there, we can intervene. These two ladies are also cases of, one is hypothyroid and one is hyperthyroid cases. All complaints of diplopia in extreme cases. Causes of diplopia in hyperthyroid is because of the restrictive pathology, and also proptosis related, the side gaze problems, and dry eye can also contribute. Here our ocular movements is almost full, but the proptosis related end gaze pathology is relating to the diplopia. A 64-year-old patient who underwent FES noticed diplopia immediate post-op. This is a 1.5 month picture, and this is 3 month post-op. Both this picture, there is growth, exotropia is there, and it revealed a limitation of adduction, gross exotropia. It's because of the medial rectus muscle was damaged during the FES surgery, and she was a little free of diplopia because that eye vision was 6 by 18 because of pseudophakia and PCO. So she was not willing for further management. This lady complains of diplopia on and off. You can see ptosis, but the diagnosis was proven with an ISPAC test, that's myasthenia gravis. Another male patient complains of diplopia for a few months. On examination, there is ptosis and gross facial asymmetry is there. Ocular movements in the right eye's full elevation is limited. There is a fibrotic changes near the maxillary sinus along with the orbital changes. Probably maybe a fibrosis related issue or malignancy. Patient was not willing for further evaluation and lost follow-up. And coming to another case, 82-year-old female, she presented with binocular diplopia and orbital pain 2 days duration. Best corrected visual acuity was 6/12. Anterior segment evaluation is immature senile cataract was there, fundus normal. Ocular movements, -1 limitation of abduction in the right eye. Orbital pain and tenderness was there. Suspicious evolving lateral rectus paresis, evaluated with MRI brain and orbit, turned out as early Tolosa-Hunt syndrome, treated with steroids, and she became asymptomatic. Coming to last case, 62-year-old female came to OPD with some irritation. She was 6/9 because of immature cataract, and again after 3 days she presented with diplopia. That time there was right eye evolving lateral rectus paresis, and neurology evaluation and MRI was advised. This is the second time visit. Can see a minimal limitation of abduction in the right eye. Evolving lateral rectus paresis is there in the right eye. But after 2 weeks, she again turned back with redness and ocular pain along with increased diplopia. That time redness in the right eye also. Bilateral lateral rectus paresis is there, and the imaging revealed carotid cavernous fistula. Here she is having bilateral limitation of abduction. Further evaluation turned out as carotid cavernous fistula. So for diplopia from orbit, we need to get a proper full history. Need to see it is whether monocular or binocular. Proper anterior segment and fundus examination is a must, along with ocular movements and imaging, and follow-up is another very important key. Thank you.
Thank you, Dr.